I'd like to introduce our Grand Round speaker this morning. This is Dr. David Moore. Dr. Moore will be speaking with us about the electroencephalogram and delirium. He obtained his undergraduate training at Dartmouth and medical school at Rochester before doing a residency in psychiatry at the University of Wisconsin. He's been an associate professor in the Department of Psychiatry here and is currently an associate clinical professor in the Department of Neurology. He's authored a number of textbooks. He's very active in the area of electroencephalography. He's a cat person, and I look forward to what he has to tell us.
Hi, good morning. What I'd like to talk about today is the electroencephalogram in delirium. And first off, I'd like to say that's not me. Some of you may know that psychiatry and electroencephalography have long been allied and very, very strongly allied early on. And in fact, the first person to record an electroencephalogram from the human scalp was this gentleman up here. This is Hans Berger. Hans Berger was a psychiatrist, so EEG actually starts with psychiatry. I put Hans's picture up there because that's Hans in a good mood. Hans was a very dour man who had some very unusual ideas that I'd just like to talk about very briefly, because if you read about Hans, you'll read these ideas. Actually, Hans's interest in EEG stemmed from his belief in telepathy. When Hans was 18 years old, he wanted to be an astronomer, and he was on military maneuvers in Germany at the time. He was on horseback, and a cannon that was being dragged in front of him went off the wheels and struck his horse, and Hans went down and hit the ground, and his head lay in the path of another caisson coming behind him. And that caisson stopped just inches from his head. It would have killed him. And he was terrified by the whole thing. He survived, of course. Later on that day, Hans got a telegram from his father. The first time his father had ever sent him a telegram in his entire life. And the telegram sent the message that Hans's sister, that morning, at about the same time this had happened, Hans's sister had had an ominous feeling that Hans was in grave danger. This had never happened before. Hans was overwhelmed by this, and he began to think that, in fact, some telepathic communication had existed between himself and his sister. Now, this may sound really bizarre to us now, but back at the time, belief in telepathy was not that bizarre, and in fact, it fit in with the reigning scientific paradigm in Germany at the time, and also in this country. You all are familiar with William James, of course. William James was a physician and one of our greatest philosophers, and he believed in telepathy. So not that odd in a belief at the time, but this started Hans on his journey towards finding how telepathy might work. And that's where his interest in the EEG came in. He initially recorded EEG from the scalp in 1924, and he was convinced at the time that he'd be seen as a crank. Nobody believed that you could record electrical activity through the skull, so he didn't publish his findings. Not until 1929, when he had some good EEG recordings that he obtained from his own son. And he published those in 1929, and the reaction was just as he feared. He was ridiculed. Nobody thought it was real. They thought he was just picking up what we call muscle artifact now. And nobody bought the idea. And so Hans retreated and stayed that way until 1934, when Lord Edgar Adrian published in the Archives of Neurology and Psychiatry an article which replicated Berger's work. And so finally, Berger's EEG hit the mainstream. And Adrian himself actually named what we now call the alpha rhythm the Berger rhythm. And for many, many years, what we now call the alpha rhythm in EEG was referred to as the Berger rhythm. Hans didn't do so well after that. He finally committed suicide. In 1941, he hung himself in one of the wards of the psychiatric asylum at Jena, where he was a professor. So Hans did not have a happy life. And again, that's probably Hans on a good day. The next picture, a much happier man, is John Romano. This is John Romano, a handsome young John Romano, on a good day. And in this country, at least, the use of the EEG after the 1934 paper went basically two different ways. There was a lot of research done, obviously, in the use of the EEG in epilepsy, but also there was a lot of use, burgeoning use, on the use of the EEG in the diagnosis of delirium and dementia. And one of the first researchers in this area was John Romano. And John Romano was a psychiatrist. And the next one of his pals, was George Engel. This is George a little bit later on. I've never been quite sure whether he's punching himself in the head in that picture or whether he's just scratching his head. But Romano and Engel authored one of the first and seminal papers on the use of the EEG in the diagnosis of delirium in 1944. It was published in the Archives of Neurology and Psychiatry, and it was published while these two were at the University of Cincinnati, just up the street. So just as an aside, Romano and Engel then moved on to the University of Rochester, where I went to medical school, and it was one of my highlights of my medical school career to be taught by these two men. That was back when professors were divinities, and these guys were gods back then. Nobody questioned them, and we certainly learned a lot from them. But it's interesting that the psychiatrists working with EEGs and reading EEGs persisted up until the 60s or so, and then we sort of backed off. And I think there are a lot of historical reasons for that, but it happened, and now it's unusual to find psychiatrists reading EEGs. I did a fellowship in electroencephalography here, and I did it just a year and a half ago. And I think it was one of the oldest fellows in the world, and I learned a lot, and I also learned to empathize with what it's like to be a resident again. My heart goes out to you guys. So what I'd like to do now is I want to go ahead and show a few pictures of EEGs, not because I think that you'll be able to learn that much from them, but I'm going to refer to these findings when we talk about the EEG and delirium, and it's sort of like talking about that without showing the pictures is a little bit like talking about arrhythmias and not showing pictures of them on the EKG. So I just want to very briefly show some EEGs. For those of you who've gone through some of this, this will be old hat. For those of you who hasn't, not so old hat. So the first one is a normal EEG. And what we have here on these recordings, blue is left, red is right, blue is left, red is right. And up here, this is the left parasagittal. And down here, this is the right parasagittal. And down here, this is the left temporal. And over here, this is the right temporal. So here we have, this patient here is awake and alert. We ask him to close his eyes, and when people are relaxed and alert and they're normal and they close their eyes, out pops the alpha rhythm. This very rhythmic activity posteriorly here. And again, that used to be called the Berger rhythm. And that's a normal finding when people close their eyes. Now, so it's called, in part, it's called the alpha rhythm because this activity in here is occurring at about 10 hertz or 10 cycles per second. So anything that occurs between 8 and 13 cycles per second is said to be an alpha frequency. Higher frequencies, 13 and above, are said to be beta. And then below that, we have theta, which is anywhere from 4 to 8, and below 4 is a delta rhythm. It gets progressively slower that way. So here we have some alpha rhythm here, and then anteriorly, it's very common that you see faster activity or beta activity anteriorly. So again, this is a picture of a normal EEG. That's what we like to see. It's normal. It's pretty. Next, what I'd like to show is something known as excess beta activity. And here you see this is the beta activity. It's very rapid in there. And here it's anterior, but here you see it some posteriorly also, especially down in here. So this is a recording that just shows excess beta activity. The next recording here, you can see that the waves are very slow. These lines here represent 1 second. So these waves are occurring at roughly 1.5 hertz in here. This shows generalized slowing. It's on the left, it's on the right, it's parasagittally, and it's in both temporal regions. So this shows just generalized slowing. That's a very unhappy EEG. Another EEG, and I want to point this one out because, as I'll make clear in the talk when we talk about various disorders, there are very, very few EEG findings which are specific for a specific disease. However, we're beginning to find some, and this is one, and you may hear this later on. This is known as extreme delta brush. What we have here is slowing. Here's another, the underlying activity here is very slow, but you see on top of each wave, you see this beta activity. That's known as the brush. An extreme delta brush, when there's a lot of it like this, it's extreme, is specific for a certain form of limbic encephalitis in anti-NMDA cases, and we'll get to that. But again, this is one of the few EEG findings that is absolutely specific. If you find this, you know what the patient has in delirium. Another finding here, so I've shown some generalized slowing, but here we have some lateralized slowing. On the left side, it's normal, but compared to that on the right side, it's not as fast. So that's another finding you can see in the EEG. For example, if somebody had a tumor over here, they just have slowing on this side, whereas this side would be normal. So we have regional slowing or lateralized slowing. This is going too fast. Another finding is something called FIRDA. It's an acronym, F-I-R-D-A, and it stands for Frontal Intermittent Rhythmic Delta Activity. And here, whoops, it went back. I'm sorry. Over here, for most of this EEG, it looks normal, except here, obviously, there's something abnormal here. And what we find an episode that starts then and ends there, so it's intermittent, doesn't occur throughout the entire recording. It's frontally predominant. It's rhythmic, bam, 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 and it's delta activity. It's very slow. So it's frontal, intermittent, rhythmic, delta activity, or FIRDA. And that's a finding you see in various cases of delirium. Finally, I tell you, this is twitchy for me. Another finding that is sort of would take a long time to go over in any detail, but I just wanted to show again a picture. There's something called triphasic waves. And they're called that because it's sort of easy to see on this channel here that we see these waves are triphasic. There's a little upward deflection there, a downward deflection, and then an upward deflection. So it's a triphasic wave. In this patient, there are bam, 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 multiple triphasic waves. Another finding, very, very important on the EEG, is what's known as the epileptiform discharge. And that's something that, as the name suggests, you tend to think of seizures when you see this. And what we find here is if you look at this recording, there's some slowing there, but it's sort of blah, there's various, except for this. This stands out. If you've seen enough of these, your eye would be immediately attracted to this. And what we find here is a very sharp wave right there. So this is what's known as an epileptiform discharge, and it's also got further named as an interictal epileptiform discharge. Interictal because this patient is not having a seizure now, or an ictus. So this is occurring in between seizures. So it's an interictal epileptiform discharge. Now, if you've been trained in electroencephalography, this gets the blood going. You see one of these things, oh boy, that's great. You want to talk about that. That's an exciting finding. I feel excited by it. And, if you've seen enough of these, you'd be excited too. Because that indicates very strongly that this patient from whom this recording was obtained has either had seizures or is at risk for having seizures. Now, here we have, this is another recording with epileptiform discharges. There they are. But the interesting thing about this recording is that these are occurring periodically. Bam, 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 bam. Like every 2 seconds, we have an epileptiform discharge. And also, so they're occurring periodically. Also, they're occurring just on one side, just on the left side. We don't see them anywhere else. So there are periodic, lateralized epileptiform discharges, or PLEDs. And PLEDs are seen typically in patients where there is an acute destructive lesion, as, for example, an infarction, an area of abscess formation, or an encephalitis in that area. So this patient, although there are exceptions, this patient probably has something destructive going on in the left temporal region. Now, these PLEDs here, these lateralized epileptiform discharges are just occurring on one side. However, they can also occur on two sides. Now here on these filled-in triangles, these refer to these lateralized epileptiform discharges, and these are occurring here on this side, but then you look at the other side over here in the open diamonds here, you see additional epileptiform discharges, and these are out of sync with these. So these are called bilateral periodic lateralized epileptiform discharges, or BiPLEDs, and this patient has an acute destructive process on both sides. And finally, you can have patients who have periodic epileptiform discharges that occur on both sides at the same time, and these are called GPEDs, or generalized periodic epileptiform discharges. This pattern is usually only seen in patients who are in coma, as for example in a post-anoxic state. Finally, perhaps the most exciting EEG finding is when you see somebody having a seizure itself. And this is an example of an ictal discharge or an electrographic seizure. So here we have the left over the right, left parasagittal, right parasagittal, left temporal, right temporal. And so here we have, it's not a very well organized EEG, but there's nothing exciting going on. But here, by the time we get over here, you can see something exciting has happened here. We have spiking occurring that is more or less rhythmic, and it's all over. So something has happened between here and here, and so what we typically do is trace back to find out when it started. And you can see tracing back here to right around here, there's a change. And that's where the seizure started in this patient. So that's an ictal discharge or an electrographic seizure, and obviously that is really exciting because sometimes, most of the time, let me back up, the most common type of seizure, of course, is not a grand mal seizure or a generalized tonic-clonic seizure. That's the most obvious one. You know, I can teach a grade school kid how to recognize that. The most common type of seizure is what we call a complex partial seizure. And sometimes those go unrecognized. And that's what this patient, in fact, was having. Whoops. Okay, well, let me go back. Now that we've looked at some of the examples, what I want to do is to talk about the EEG in delirium and its utility and some of the things that you might find. Now, as we go through this, what I'd like to do is, if people have questions or comments as we go along, I'd like you to go ahead and raise your hand or just speak up, because I want to be able to speak to what your interests or what your concerns are. I have stuff that interests me, but it may not be that exciting to the folks out there. So again, if you do, I'd rather that you not wait until the end, but just go ahead and speak up. Okay, so the utility of the EEG in delirium. There were two studies done here. Now, I've gone ahead and put the references up here, but for those of you who are obsessive like me and like to look at references, they're also in the handout. I could only find two studies that went ahead and looked at the actual utility of the EEG in delirium. The first study was done, this one up here, was done on patients this is a prospective study, done on consecutive patients who came into the emergency room with altered mental status, patients with a delirium. And as part of their routine workup, this is before anything else is being done, before their CT, blah, 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 just as part of their routine workup, they all had an EEG. And so what they wanted to do, what the researchers wanted to do, was to check with the attendings after the patient had had their full workup, all their blood testing, their CT, their MRI, plus the CEG, and they wanted to check with the attending and find out whether or not the EEG was useful. Well, the results were interesting. It looked like, according to the attending, that the EEG helped establish the diagnosis in 56%, changed the diagnostic workup in 49%, and changed the overall treatment plan in 42%. So roughly half the time, the EEG was felt to be very useful by the attending in the emergency room. And what did they find? Well, in 7% of the recording of the patients, the recording was normal. Slowing was found in 79%, and that is the most common finding in delirium that you'll see on an EEG. But what was very interesting is that in 4% or 2 of these patients were found to be in complex partial status epilepticus, which is to say that when they walked into the emergency room, they were seizing, and nobody knew it. And it was only with the EEG that they could determine that, in fact, the cause of the delirium was status epilepticus. And that occurred in 2 patients. Well, that sounds like a lot. That sounds like a lot to me for patients just routinely walking into the emergency room with altered mental status. Well, it gets more interesting. The second study that I found was a retrospective study of 15 elderly inpatients. Now, these were patients who had been admitted and had been worked up. They'd had their MRI, they'd had their blood tests, some of them had lumbar punctures. They had been thoroughly worked up, and the cause of their delirium remained unknown. So these patients were given a routine EEG, which lasts 20 to 30 minutes, and then they were hooked up to continuous EEG, so an ongoing continuous recording. And what they found was that the routine EEG revealed complex partial status epilepticus in 2 of these 15 patients, and the continuous EEG recording revealed complex partial status epilepticus in 4 additional cases, which is to say that overall 6 of 15 patients, or 40% of those with delirium of unknown cause, were in fact in status epilepticus. And I think the importance here is that there are only 2 ways to make this diagnosis of complex partial status epilepticus in a patient with delirium. One, you could pursue a diagnosis by treatment response. Go ahead and give them Ativan, 2 milligrams, and if they clear within 1 to 2 minutes, well, that's what was going on. But the problem is you can get false negatives there. There are patients in complex partial status epilepticus who do not stop with Ativan. You've certainly seen that in patients with grand mal status epilepticus, but it's also true in patients with complex partial status epilepticus. So if you go ahead and give the patient 2 milligrams of Ativan or follow it up with another 2 and they stay confused, well, it could be because they're still seizing. So the only way to make the diagnosis with certainty, the only way, is with an EEG. And I think it's grossly underused. This is one of those situations where ordering a stat EEG makes enormous clinical sense. Because again, 40% of patients with delirium, of elderly patients with delirium of unknown cause, were in fact in status. So what I'd like to do is briefly talk about the kinds of status epilepticus that you can see that are non-convulsive. And there are basically 4. This is just not happy. Okay. The first kind is ictal coma. A certain percentage of patients in coma are going to be in coma because they're in status epilepticus. Or allied to that is ictal stupor. But the more interesting ones for us are complex partial status epilepticus and absence, if you want to speak with a French accent, or absence if you don't, or what we used to call petit mal status epilepticus. And the important thing is that complex partial status epilepticus and absence status epilepticus typically present with a delirium. That's how these patients show up. So let me talk briefly about complex partial status epilepticus. Now, the typical complex partial seizure lasts on the order of just a few minutes. Now, paroxysms will start, patients become confused, you may see some lip smacking, other symptoms, and it goes on for generally no more than 5 minutes, and then they're better. So it's, if you have a competent historian or if you're there looking at the patient, it's pretty obvious what's going on. However, complex partial status epilepticus is a different story, and the duration is much longer. I found 2 studies that looked at it specifically. The first looked at 20 patients with status and found that the confusional state, as they called it, lasted from a few days up to a few weeks. That's a patient in status epilepticus for weeks. Another series of patients found that the average duration of status epilepticus was 32 hours. That may sound like a long time, and it is a long time. However, I want to emphasize that there are definite case reports of complex partial status epilepticus lasting much, much longer. These are EEG verified cases. There was one case that lasted 4 months. A patient was in status. Yes? Well, it would depend on the etiology of the catatonia. I mean, in terms, for example, in schizophrenia or other etiologies, depression, or. Well, I think if the etiology of the catatonia wasn't clear, for example, if the patient wasn't clearly in the midst of an exacerbation of schizophrenia or clearly wasn't in the midst of stage 3 mania, whatever. But if you didn't know, I think it's worth doing if it's not obvious. And the reason I think it's worth doing is because a significant minority of patients in complex partial status epilepticus will be catatonic. And that includes not only they're immobile, but they'll also have waxy flexibility. So I think it's very important to do because, again, complex partial status epilepticus can present that way. So, yeah. Okay. So that, again, complex partial status epilepticus can last a long time and is one of the ways that can cause, one of the causes of delirium. Now, absence status, let me give you an example, though, first. This is an example I got from one of the papers of a patient in complex partial status epilepticus. So she got, 51-year-old female, got confused, disoriented, started making bizarre statements. She expressed some bizarre fears, some delusions. Dogs are barking and howling. This is sounding pretty bizarre. She's brought to the hospital. She's disoriented. She's behaving inappropriately. She's babbling in her speech often, grossly impaired memory, didn't know what was going on. The next day went ahead and gave her an EEG, revealed status, and she was given, in this case, she was given this a while back, she was given phenytoin, and she cleared. Let me talk briefly about absence status epilepticus. Absence seizures or epidemial seizures, typically we think of those as being very brief. Seconds, no more than a minute, just sort of the kid blanks out, or if they occur in adults, they just staring spell and they're gone. And that's the case. But absence status is an entirely different matter. And it's interesting, absence status can also be extraordinarily prolonged. In one series of 21 adults, what they found was that the episode of absence status ranged in duration from a half an hour up to 10 days. I mean, we just don't think of patients with epidemial epilepsy having seizures lasting days, but in these cases, they could last up to 10 days. And here's an example of absence status, which I thought was great. This is a 19-year-old woman working at her father's office. It was a law office, and she suddenly became confused, incoherent, forgetful, and they didn't know what was going on, so they brought her to the hospital 8 hours later. And in the hospital, she was disoriented and confused, poor memory. She was delirious. And the only thing on examination, which should have been a tip-off at the time, was that she had continuous fluttering underneath her closed eyelids. And myoclonic fluttering of the eyelids is, if you've seen patients with a typical epidemial seizure, that's very common. And this patient had it when she was in status. So they went ahead and eventually did an EEG, and she was treated with the barbiturate. This is a long time ago. And it took a while for the barbiturate to get up to speed, and 16 hours later, however, the EEG and she were completely back to normal. That's sort of a diagnosis by treatment response there. So again, absent status can be very, very long-lasting, just like complex partial status is. So what I'd like to do, turn away now from looking at seizures, which we'll come back to again and again, but I want to talk about the various kinds of delirium and the kinds of EEG findings that you will see in these. And the most common type of delirium, of course, is a toxic metabolic encephalopathy. And the cardinal finding in a toxic metabolic encephalopathy, as determined by Romano and Engel back in 1944, is generalized slowing. And this is the most common thing you'll read on EEG reports when you order them on somebody that you suspect of a toxic metabolic encephalopathy, is there was generalized slowing. So let me talk about a few classic metabolic. Let me back up. The literature on electroencephalography in delirium is absolutely vast because it goes back to the 1930s. And so what I've had to do to make this of interest and to narrow it down to the time frame is just to choose some classic sorts of deliria and the EEG findings seen in them. And one of the most classic, of course, is hepatic encephalopathy. And this is characterized by slowing. That's the most common finding in anything. And the degree of slowing correlates roughly with the severity of the delirium. It's interesting that the EEG used to be, it's not so much anymore, but it used to be we talk about patients with minimal cognitive change in hepatic encephalopathy, sort of not rising to the level of clinical significance. And those patients will have, as you might suspect, very minimal amounts of EEG slowing. The other thing that you find or will read in reports is triphasic waves. Triphasic waves are absolutely classic for hepatic encephalopathy. And in fact, they were initially found in patients with hepatic encephalopathy. And for a while, it was felt they were absolutely specific to hepatic encephalopathy. They're not, but they are very, very common. It's very important if you have a patient you suspect of hepatic encephalopathy and the EEG comes back just with slowing but not triphasic waves, it's important to keep in mind that you may have to do more than one EEG to capture them. They may simply be absent while the patient is getting the EEG. Interictal epileptiform discharges can also be seen along with bipleds and GPEDs, those examples that we talked about earlier. Whoops. Okay. Another classic metabolic delirium is uremic encephalopathy, and this is characterized by slowing, typically. And an interesting little wrinkle to this is that patients, when they get dialysis, if they had EEG slowing prior to the dialysis, as most of them do if they get to this point, their EEG gets slower during the dialysis. Even though their numbers look better at the end of their dialysis, the EEG is going to be worse, and it will stay worse for several hours afterwards. So it's very important if you're ordering an EEG for somebody who's got renal failure and is having dialysis to make sure you time it appropriately if you want to get the most diagnostic use out of it. And what I recommend doing is to make sure you time it for before they get their dialysis session so you don't complicate it with the effects of dialysis itself. In addition to slowing, you also see triphasic waves can occur in minority. And the interesting thing is that in uremic encephalopathy, FIRDA, that's that example I gave earlier, occurs in a majority of cases. So FIRDA is a very common finding here in uremic encephalopathy. Let me turn now to toxic delirium. And here's where I think the EEG can be a whole lot more interesting than the metabolic cases. Let me take, for example, baclofen, which, is a bad actor when it comes to delirium. Baclofen, let me just say a word about that. When I was doing consults over at Jewish a few years back and at Fraser, what I found was that the orthopedists, and my apologies to those of you who want to go into orthopedics, but the orthopedist would routinely, after somebody got a hip done or anything similar to that, they'd want to make sure the patient was real limber and loose after surgery. So they would automatically start somebody on baclofen even before they basically got a recovery room. There would be the order for baclofen, which is fine if you're going to start at 5 milligrams TID or something like that. But these guys were starting at 20 to 30 milligrams TID, immense doses of baclofen. And seeing a baclofen-induced delirium can be sort of almost bread and butter for me for a while. I hope they've stopped doing that. In any case, with baclofen toxicity, what you find is slowing, obviously, but you can also find furta. And the interesting thing is this can be a tip-off to the fact that delirium can occur with baclofen at even a low dose. For example, in this case here, this patient was delirious, and they were only on baclofen 10 milligrams TID, really not that much. And it wasn't clear whether or not this could possibly account for the patient's delirium until the EEG was done. And this showed up furta, and this convinced the author that, okay, this is secondary to baclofen, stop the baclofen, delirium cleared up, EEG normalized. Another finding, triphasic waves can also be seen, and this was another example. Here was a low dose of baclofen causing delirium. The tip-off was the triphasic waves that alerted the author to the fact that this could be a delirium secondary to baclofen. Now, the other interesting thing, this is going to be an example of this, is that many medications which are capable in and of themselves of causing delirium by direct generalized effect on the cerebrum can also cause delirium indirectly by triggering off complex partial status epilepticus. So, for example, the scenario would be something like this. Let's say you have a patient who you're called, they have delirium, you've looked over all the metabolic parameters, you've looked at the various medications they're on, and it looks like the delirium started after, say, for example, baclofen, in this case, had been increased up to 110 milligrams. That's an attention grabber, a relatively high dose of baclofen. So the obvious culprit then is the baclofen. And what happened here is that the baclofen was stopped and the patient didn't get better. The patient continued to be confused, grossly confused over the next few days. And so everybody was left scratching their heads because this was the last option, this 110 dose of baclofen, and there was no other obvious cause. They went ahead and got an EEG, and what they found was that the patient was in complex partial status epilepticus. And what had happened in this case was that the baclofen had triggered off a case of complex partial status epilepticus. So the rule here is that if you have a patient and you suspect that they have a toxic delirium, there's no other obvious cause, you stop the offending agent and they don't get better or they get worse. That's an indication for a stat emergent EEG to see whether or not, in fact, a case of complex partial status epilepticus has been triggered off. If you look at another, cefepime, cephalosporins in general, but cefepime in particular is a bad actor when it comes to causing delirium. And what we find on the EEG is typically delirium only occurs when cefepime is given to patients in renal failure when you don't adjust the dose properly. And there's usually a several-day lag. And generally what we find is that the EEG shows slowing. However, just as with baclofen, cefepime and the cephalosporins in general are much more likely to do this than baclofen is, can trigger off complex partial status epilepticus. And what I did here is there were actually, these two cases were very, very clear-cut. There are over 30 cases documented in the literature of patients in complex partial status epilepticus presenting as delirium that was triggered off by cefepime. And this patient became delirious 2 days after cefepime was begun. The EEG revealed status, gave them IV diazepam. Click, within a minute or two, they were back to normal. That's really rewarding, by the way. I hope you all get an opportunity to do that. In another case, a patient with normal renal function, even though you didn't have to adjust the dose of cefepime, this patient did become delirious, And on day 3, the EEG reveals status, given some Ativan, bip, again, they're better. So again, if you have a patient, cefepime, of course, by itself can cause delirium. So if you have a patient, again, who you suspect of a toxic delirium, you withdraw the offending agent, they don't get better, think about complex partial status epilepticus. And finally, I want to talk about lithium. Lithium, when I was growing up professionally, and when Steve was growing up professionally, was bread and butter. It's not used as much now, but you'll still see it. Lithium, if there's too much on board, can cause generalized slowing if the patient gets delirious. But interestingly, there is not a good correlation between the serum lithium level and the presence of delirium with EEG slowing. For example, there are certainly cases, like this is a case of delirium secondary to lithium with a level of 2.4. However, delirium can show up when slowing is present, but the lithium level is well within the therapeutic range, 0.9, 0.72. And the reason for this is that there is a better correlation between slowing on the EEG and the lithium ratio, not the serum lithium level. And this is a study here, and I'm going to go to the next, which I have in a table here, which was done in Poland, and a very interesting study. What they did is they had patients these patients weren't delirious, but some of them got lethargic. And what they had were patients who they had 21 patients, and what they had were some patients had a normal EEG, 10 of them, and some patients presented with slowing on the EEG. So the first thing that they looked at was the serum lithium level. And in those who had a normal EEG, it was 0.7 on average, and those who had slowing, 0.92. Not a big difference and not statistically significant. So what they did next was look at the red blood cell lithium level. And what they found is that those with a normal EEG, although their serum level was 0.7, their red blood cell level was low at 0.34. Those who developed slowing, here's their serum lithium level, and here is their red blood cell lithium level, and that's a bunch higher than here, and in fact, it is statistically significant. And another derived measure, which you'll read about, is the lithium ratio, and that's the red blood cell to serum lithium level. And what they found was that the red blood cell lithium ratio here, in those with a normal EEG, the ratio was 0.4, and those with slowing was higher, meaning that they had a relatively higher red blood cell lithium low at 0.75, and that was significant. So, so different people have different amounts of intracellular lithium with the same serum lithium level, and the EEG, slowing on the EEG, correlates better with the intracellular lithium level. So it's actually a better guide of how much it's getting into where it needs to be in the neuron. Unfortunately, we're not able to get, unless it's recently changed, we're not able to get red blood cell lithium levels. We're not able to calculate a lithium ratio. It's not available to test. It could be, but they're not. So in these cases, if you get somebody on lithium and they have a slowing on the EEG, you can bet that probably their lithium ratio is relatively high, and you might want to go carefully, even if their serum lithium level is within the therapeutic range. So, another thing that I always wanted to look for was the same examples as with baclofen and cefepime, and the question is it possible that lithium can cause complex partial status epilepticus? And the answer is yes. I found 3 cases in the literature. 2 were not convincing. This one, however, was indisputable. What they had was a patient, an adult had been started on lithium recently. She had bipolar disorder, been started on lithium, and she became confused. Clearly not a manic episode or a depressive episode. Became confused. She was admitted. They worked her up, couldn't find anything, so went ahead and got an EEG. And the patient was in status. So they went ahead and gave her some Ativan, stopped the lithium. The Ativan cleared her immediately. They stopped the lithium, kept her in the hospital, and she got back to her premorbid baseline. So the question is, Was lithium causing this, or was it just a coincidence? Does she have epilepsy for some other reason? We just happened to catch it when she was on lithium. So what they did is they re-challenged her, put her back on lithium. She was doing fine for 2 days. Then she got suddenly confused. They got another EEG. She was in status. They went ahead and gave her some more Ativan. She came out of it, stopped the lithium, no more lithium for her, and no more episodes of confusion. So although it's a very rare bird, complex partial status epilepticus can occur even in lithium. Another cause of delirium that I want to talk about that is, so very common in the hospital are the DTs, or delirium tremens. And the reason why I put this up here is because this is the one exception to the general rule that delirium on the EEG presents with generalized slowing. This is the exception. And that is because although slowing can occur, much more commonly what you find is excess beta activity is characteristic of the DTs. And there were several studies, pretty old, older than me, some of them, and what they found was that the vast majority of cases of patients in the DTs, when they had an EEG, had excess slowing or excess beta activity, faster activity on the EEG. Now, excess beta activity is most commonly seen with benzodiazepines or propofol, and so that can create problems because many patients who are alcoholic and coming in the hospital, they'll end up being given some Ativan or Valium or Librium or whatever, something like that. And so if they then become delirious and you get an EEG and they have excess beta, well, it could be because they've already gotten some Ativan, or it could be because they're going on the DTs. So that's a hard one to decipher. But if you have a patient who is an alcoholic, or you don't know if they're, that part of the history is hidden from you, and they don't get any benzodiazepines, and they become delirious, and you do the EEG, and it comes back showing excess beta, then that's what you probably got. And family and patients are hiding the history, and that's what you should be treating. And this is the exception to the rule of generalized slowing on the EEG in delirium. Okay. Next, what I'd like to talk about is the EEG in the autoimmune encephalitides. And that's because the EEG in the autoimmune encephalitides can be very, very helpful. And in some cases, it's diagnostic. So there are various kinds of autoimmune encephalitides. The three I'm going to talk about are limbic encephalitis and Hashimoto's encephalopathy and lupus cerebritis. So the first one, limbic encephalitis, this is, I put down the typical presentation here. It's a subacute onset over a day or a week or so of delirium. They often have obvious seizures, like generalized tonic-clonic seizures, but not always. There can be personality change, hallucinations, and delusions. And the etiology is most cases are paraneoplastic. However, some are not secondary to some other cancer, but occur on a non-paraneoplastic basis. And there are two basic varieties here. And bear with me, I know it may be more detail than you want, but one is secondary to LGI1, or leucine-rich glioma inactivated number 1. This used to be called anti-voltage gated potassium channel antibodies, and this has a slightly different presentation. And the other one is due to anti-NMDA antibodies. And let me talk about the EEG findings. Generalized slowing, of course, that's the common finding in delirium. Interictal epileptiform discharges and PLEDs can occur. And then I talked about earlier the extreme delta brush. And this is a finding seen in only about 5% of cases of anti-NMDA limbic encephalitis. However, the sensitivity is low. However, the specificity in adults seems to be 100%. It's not been found in any other cause, any other condition. So if you find a report coming back saying appears to have extreme delta brush, and you hadn't already been considering an anti-NMDA caused limbic encephalitis, that's what you've got. Next thing I'd like to look at is how does the EEG stack up with an MRI scan? We're also thinking about doing an MRI scan. So these studies here, what I have here is on this column here, this is these are studies done, and the references are in the handout. These are studies of patients with limbic encephalitis who all of them had an MRI scan done within the first 2 days, and all of them had an EEG done within the first 2 days. That's the critical time I want to pick up on today. So we have some patients who had a normal MRI scan, and most had an abnormal one. Some patients had a normal EEG, and some had an abnormal EEG. And the important thing is that 2/3 of the cases, roughly 2/3 of the cases, the MRI was abnormal and the EEG was abnormal. In about 1/10 of the cases here, the MRI was abnormal and the EEG was normal, so the EEG didn't pick it up. And over here we have cases of MRI normal and EEG abnormal, also about 1/10. So in about 10% of cases, the MRI scan in early limbic encephalitis is normal, where the EEG is abnormal. So if you get a patient coming in and you don't know what's going on, you suspect maybe limbic encephalitis, but you're not sure, you get the MRI scan, it comes back normal. The next thing to do is to go ahead and get a stat EEG to see whether or not this patient may be that small percentage there where the MRI scan is normal, but the EEG is abnormal. Next, what I'd like to talk about is Hashimoto's encephalopathy. It's a favorite of mine because it's so easy to diagnose and so easy to treat, relatively speaking. And these are patients who show up with a subacute delirium, and they typically have other symptoms, and I've listed them up here. But let me talk about the EEG findings. Now, typically generalized slowing is seen, very common. You can see interictal epileptiform discharges, but they're uncommon. The pleds are very rare. But the big question is, how does it stack up against the MRI scan? Same organization of the table here. And what we have over here is that the EEG is abnormal and the MRI is abnormal in just a small percentage of cases. Both of them. If you look at cases where the MRI is abnormal and the EEG is normal, again, it's only about 10%. But here's the exciting one. These are cases where the MRI was normal and the EEG was abnormal half the time. Half the time when you have a patient with Hashimoto's encephalopathy, the MRI will be normal, but your EEG is going to be abnormal. So again, if you suspect that somebody has Hashimoto's encephalopathy, let's say, and you've ordered their antithyroid antibodies, and they come back, well, all right, they're elevated, they're not off the map, maybe it is, maybe not, maybe they have a past history of Hashimoto's thyroiditis, and this is just a red herring, yada, yada. That's a case to go ahead and get EEG, because if that comes back with some cystic abnormalities on it, even if the MRI is normal, you're not probably not. And that justifies a diagnosis by treatment response strategy for that patient. Let me talk about lupus cerebritis, another one that sort of flies beneath the radar. There neuropsychiatric lupus, that's the phrase the Rheumatology Association uses, can occur secondary to basically two different etiologies. The most common one is stroke. It can be embolic, thrombotic, or rarely vasculitic. But the other cause is an autoimmune cerebritis, and hence lupus cerebritis. Clinically, this is characterized by delirium, and you can have hallucinations or delusions, and occasionally there can be grand mal seizures. The EEG findings are typically slowing, seen in about 1/3 of cases, and this can be accompanied by focal accentuation. Other findings can be seen. You can see interictal epileptiform discharges or pleds, but they're relatively rare. So I'd like to look again at how the EEG stacks up with the MRI scan in lupus cerebritis. Same table here, same organization. So over here, you can see here are cases where the MRI is abnormal, and the EEG is normal. Here they're both abnormal. But this is the kicker, and this is the most important one. Here are cases where the MRI was normal and the EEG was abnormal 2/3 of the time. So most of the time, if you have somebody with lupus cerebritis and you do the MRI scan, it's going to be normal. But the EEG will tell the tale. So since lupus cerebritis is one of those tricky diagnoses to make, and there are lots of internists out there, they almost act like they don't believe it exists. It's important to keep in mind that the MRI don't depend on it. It may be abnormal, but it's typically normal. And again, this is a case where it should be a reflex action to go ahead and get your EEG. And the other thing to think about, as with the toxic encephalopathies, is that complex partial status epilepticus can occur during these autoimmune encephalitides. And this has been documented in patients with limbic encephalitis, Hashimoto's encephalopathy, and lupus cerebritis. And the same scenario occurs. Let's say you're certain that the patient has one of these. You go ahead and put them on steroids or whatever you're going to be using, and it's been long enough. They should be getting better. You're fairly confident of your diagnosis. They don't get better. If you haven't done an EEG at that point, that's the time to do it, to see whether or not, in fact, the autoimmune encephalitis has triggered off a complex partial status epilepticus. The last thing I'd like to talk about is herpes simplex encephalitis. That's the diagnosis nobody wants to miss. So characterized clinically, of course, by delirium, often with bizarre behavior, delusions, and hallucinations. And the EEG findings that you see in herpes simplex encephalitis are slowing. Now, obviously, that the pathology is in one or both temporal lobes, so you typically see temporal slowing. You may or may not see generalized slowing, but you're going to see temporal slowing. And since this is a destructive process, PLEDs are seen in roughly 1/2 of cases. So the classic finding on the EEG in somebody with herpes simplex is that they'll have left or right temporal slowing with PLEDs on that side. That's absolutely classic. And that should always raise the possibility of herpes simplex. So how does the EEG compare with imaging in herpes simplex encephalitis? Well, I found 2 studies. The first one is by Al Shakli here. And what they did is they studied patients within the first 48 hours, and they had 10 patients. And all of them had okay. All of them had an EEG, and all of them had imaging. They had either a CT or an MRI scan done within the first 2 days. And what they found was that EEG abnormalities included PLEDs and or focal temporal slowing, so they could have either of those or neither. And what they found was that all 10 patients had normal imaging. And in those 10 patients, 9 of them had these characteristic changes on the EEG. That's pretty stunning. But this could be a straw man, because of these 10 patients who had imaging, 8 of them had CT scans, which are notoriously insensitive when you're looking for early changes in herpes simplex encephalitis. 2 of them, however, did have MRI scans. So whether or not that applies to modern practice is not clear. So what's interesting is you go ahead and look at a comparison with MRI scanning. This is another study that looked at 45 patients within the first 2 days, and all of these patients had an EEG, and all of them had an MRI scan. And this study was not entirely comparable to the first one because this one did not report on slowing. It just really ticked me off. All they reported on was whether or not pleds were present. They didn't ask whether or not there was focal temporal slowing, which makes it problematic. In any case, what they found was still in place.